Is wonderful. We have an amazing group of experts here with us today. And what we're here to talk about is this notion of transforming healthcare and this old analogy of man versus machine, or really is this man and machine? It's a great debate and a great conversation we're going to jump into today. And Secretary Shulkin, before I toss you our first question, I want to just set a little bit of a health economics background that frames the size of the need, the opportunity, and the challenge. In 2000, we spent $1.4 trillion as measured in GDP on our total healthcare economy. Fast forward 24 years, we're spending 4.5 trillion in 2024. The interesting and maybe ironic notion of this is that we spent 1.4 trillion on everything in 2000. In 2023, 2024, we spent 1.4 trillion just on Part A, hospital spending. So we went from 1.4 trillion being everything in 2000 to 1.4 trillion being just part of the 4.5 trillion we spend today, that 1.4 being the hospital spend. Now, to put this in perspective, if you were to look at the world's largest companies, Walmart, you would look at taking twice the annual revenue of Walmart just to equal what we spend on Part A and the hospital spend, right? Pretty big Walmart. If you look at Amazon, of course, Amazon is making its way into healthcare. It's doing a lot of things in a lot of industries. It's 2x, a little more than 2x what Amazon's annual revenue is, again, just to reach that 1.4 trillion that we spend in hospital care. Now you look at United Healthcare, big company in healthcare, right? You take their annual revenue and multiply it by 4 just to get to that 1.4 trillion. And then you go down the list to these other small companies, maybe someone like Starbucks, you would take their annual revenue by about 45 times to equal the 1.4 trillion that is just hospital spending. So this is sort of what is before us. And in the environment that we're in the payer world, there's all kinds of movement. We're just coming off, we're here today on the day of the election. We're just coming off news of a payment cut that's coming down potentially to the provider space. And so we keep growing medical spend. We don't necessarily have more revenue. And so the question becomes, how do we fix some of these longstanding problems that ultimately threaten so many different parts of healthcare? And at the end of it, all of us who need that care. So Secretary Shulkin, you have great experience as a clinician and a provider running health systems as the secretary of the VA and an entrepreneur. And you've had the opportunity to have real depth over, many different views of this. And I'll just throw out the first question to you. What changes have you seen in the course of your career? What has changed? What has stayed the same? What are you excited about?
Thanks for having me on today. You know, I'm thinking to last week where I was invited back to chair a committee at the University of Pennsylvania health system where I started my career. And when I went back on campus this past week, I couldn't help but notice the campus. I could barely recognize it. There were all new buildings. There's a proton therapy machine, a center for advanced care, new towers, unrecognizable. But when you go inside the buildings into the exam rooms, the care that's being delivered, the model of clinical care, is exactly the same as it was 30 years ago. Patients are still waiting too long, difficult to get appointments. They have an interaction with their provider. This time, the provider really doesn't really look at them because they're spending their time recording into a computer. And the patient still leaves with the questions. I wonder what happened in the, what the doctor actually said to me. How do I follow up with the patient? So, what's interesting is, and I think you described it well, we've invested a lot of money in infrastructure, in technology, but I'm not sure that we've really fundamentally changed the patient experience and certainly often the quality of the care that's being delivered. In fact, you hear more complaints now about the healthcare system than I think ever before. So the missing piece has been really engaging the patient in their experience, getting them to be accountable for their own health, getting them involved in a realistic way, whether it's either in payment of services or in personalized decision making about their own health choices. And I think that we have to start looking towards integrating the way that payers, providers, and patients really are aligned to get us the right health outcomes, which of course are improved clinical outcomes, but also affordable care that's accessible. And that still, unfortunately, is an objective that in many communities we just haven't yet achieved.
Yeah, really well said. Um, Paul, you've been uh, in many corners of healthcare, really trying to understand and improve the experience on the delivery side, on the payer side. And, this notion of man versus machine, man with machine, can you share what you've seen and successes and challenges and what you're excited about as we look forward to this notion of experience, personalization, us as consumers getting the value that we expect from other parts of our lives?
Thank you, Dan, for having me on today. I really appreciate it. And I echo really how
Thank you.
Secretary Shulkin stated the problem. And I think it's really important to start with stating the problem that we're seeing in healthcare. One of them being that the payers and providers, along with the patient, need to engage in their healthcare. But the challenge is that often, from a consumer perspective, what I've noticed is that companies continue to miss the mark in a lot of ways. They, they can provide many examples of amazing products that they're developing that will help with keeping people healthy or helping them, from getting sick. The problem is they fail to connect those solutions in a way that matches how the members or the patients view the company. For example, in healthcare, consumers often find the experience of finding care, scheduling care, getting care, and paying for that care, it's not seamless at all. That's the experience that they're happening, that's the experience that they're having. In reality, their experience is very fragmented, and it puts a lot of responsibility for figuring out how to achieve the goals that payers and providers want them to achieve. It places that responsibility right on the member themselves. So it's not for a lack of good intentions between the payers and the providers. It's just that organizations don't operate in that way. They're just not organized in a way to deliver on behalf of the patient. So that's the problem. And then the question is, okay, so how do we kind of get to that
Absolutely.
solution?
And
Sure.
I want to go a little deeper there with you, Paul. From from the depth of your experience, you've been at this, and people, process, technology. It takes all of that to get this to happen. What about this notion of, um, we can send a message or do something, but can we really connect properly? Do we really understand the audience? Are we supporting their ability to change behaviors? I know this is something you've been near and dear and been wrestling with for years. What can you share about what you've seen and what works and what it's going to take? I mean, we sort of know what the problem is. It's well stated. How do we move the needle?
Well, first and foremost, we have to see ourselves. The companies need to see themselves as the patients or the members see us. And that is literally what it requires is to turn the organization on its side, more horizontal rather than being so siloed. So focusing on that member and what is that member journey? How are they moving through getting care, paying for that care, even scheduling care or trying to find the care that they need. And sometimes they don't even know what the care is. So we need to understand who those members are and then wire ourselves into those decisions that those patients are trying to achieve. And that is the only way that we're going to start to build trust with the patients and with our members as payers.
Yeah, so Paul, I think where I was going was you've been at this, in the weeds appropriately for a really long time, and we know there are significant challenges between these entities partnering and working together, and sort of tongue in cheek, I like to say, when do we stop admiring the problem, and when do we start to fix it or know that we're on a path that feels different, and what does that look like?
Well, first and foremost, Dan, we have to see ourselves in the same lens and through the same lens as the people that we are serving. So often we focus on more of how we operate internally, but if when we start to see ourselves as our consumers or our patients see us, then we can truly start to understand the challenges that they go through. What does it mean for them to try to find care and get care and pay for care? And until we do that, or when we do that, we truly start to build trust with the people that we're serving. So we map that current state experience. We understand. We start to understand what good looks like, and then we measure. We try to measure what good looks like, because if we're not measuring what good looks like, if we're not measuring what the outcomes are, and we're not stating what those outcomes that we want, if we're not stating them up front, then we're just sort of meandering around and hoping for the best. And so, you know, seeing ourselves as the people that we serve see us, to build trust, understanding what good looks like, and then measuring and continually measuring what that good looks like. I look at it in terms of three ways to measure. Number one, success. Did the member or the patient get the job done that they wanted to get done? Second, effort. How easy or how hard was it for them to get that job done? And then thirdly, how do they feel about it? Are they happy? Are they mad? So emotion is a really important measurement there.
Yeah, very helpful. Marten, really excited to get your perspective about what you've been building at Lirio with the team. Um, I think it's no surprise that everyone today uses can I buy the vowels of A and I if this were Wheel of Fortune, right? And it's sort of thrown around at this point. But really, can you share how you approach this at Lirio? This notion of Paul talked about trust, right? And how do we build that trust and personalization with the person at the center, and how you're attacking that problem? Again, we have hills to climb, and we need to climb faster than traditionally we have as the spend keeps going. And the world of the payer is changing right before our eyes in terms of what they have to achieve in terms of cost and quality and efficiency. So share a little bit about how you're approaching that at Lirio.
Thanks, Dan. Yeah, at Lirio, we've been hard at work building a solution that we call precision nudging. And if you think about um, who we're nudging, it's of course the member, it's the consumer, it's the patient. And starting to build trust starts with, do I, as a consumer, feel that you've earned the right to uh, talk to me, to communicate with me, to try and influence my choices? When you're empowering me or you're influencing my decisions, do I feel you're doing that because you know me and you have my best interest at heart? And so the way in which we communicate in today's world is very different than it was 20, 30 years ago. One of the experiences that we as consumers have in a number of industries using a number of tools and applications is we voluntarily give up data about ourselves to help those who serve us, those who support us, those who are uh, um, looking to guide our decisions, we're offering them data about us so that they can do a better job serving us. And in healthcare, we don't have as much data about our patients. Oftentimes, it's clinical data managed in the EHR. But boy, if you have data about me and you're not using that to properly make suggestions about what I should be doing, or if you're not offering me appropriate set of choices for the things that you believe are important to my health, you very, very quickly undermine the trust that I have in you. And so precision nudging really is important as a concept because it uses data about the consumer to know who the consumer is. That's one aspect of precision. The other aspect of precision is we need to be very precise at how we target the consumer with recommendations, with choices. And so, from our perspective, we are doing something that we believe wasn't previously possible, and that is really personalized to an N of one how we communicate with each individual and make sure that they feel that the choices they are presented with are appropriate and that we have our their best interest at heart. And I think it shows in terms of the outcomes that we're seeing in how this technology is deployed and used that as we are getting to know consumers better over time, indeed they are responsive and show up for the behaviors and the choices that we're giving them. And so we're seeing a huge impact on outcomes, and happy to share more about that later. But we absolutely believe that the key to being successful in healthcare, is really understanding that the consumer doesn't really discriminate between who interacts with them, whether it's social media, whether it's a teacher at school, whether it's an employer, or whether it's a physician, right? We all live, work, and play in an environment where technology is part of our day to day lives. And we discern very quickly if technology is not designed the right way, certainly if it's not personalizing and using data the right way.
Marten, I want to follow up on that a little further because $4.5 trillion every year is a lot of money. And Paul, you talked about a lot of companies who are targeting this and they have these products and people have this idea and almost an ideal that we should just be able to change this, right? And Secretary Shulkin, you mentioned at the beginning of our conversation, you went back to where you started 30 years ago and not much has changed, right? And so it's this irony of all of this technology, not much has changed, but we think and hope that what we experience in the rest of our life can happen in healthcare. Of course, there's been some spectacular failures because healthcare, after all, is hard. Marten, can you talk about how you view healthcare and the use of that science, that behavioral science and AI, and sort of the hubris or the how you're being very thoughtful and careful about attacking this in healthcare because it isn't just the same, right, as other industries.
Yeah, listen, in healthcare, there are a couple of things that are very unique that other industries that are using AI, using data to target people with different services online are just are not having to address. And a couple of ones that are obvious and maybe intuitive for people: we don't interact with the healthcare system as frequently as we do with, let's say, Starbucks that you mentioned, right? I probably order a coffee a couple times a day. We won't get into the details, but whether I'm Netflix, Amazon, Starbucks, in a household, we have multiple interactions with these companies, multiple transactions with these companies every day, every week, every month. What that means for these companies is that they have more data about us. They collect data with every transaction and they try to predict how to better serve us in the next transaction, how to better get more share of wallet or more time spent online in that next interaction that we have. So to just have more data, and that's a huge differentiator. And
Yeah.
another thing that they have is usually a fairly defined product catalog. When I go to Starbucks, I have a set of choices before me, whether it's on my mobile app or in the store. If I go to Amazon, I usually have a product catalog, and I may have certain recommendations, certain incentives, but there are a finite set of choices that are presented to me. And even when I log into Netflix, the movies that are recommended to me are going to look a little bit different than for Paul, David, and you, right? And so the way that that choice architecture is designed to help us make choices, it uses some of that data, some of those interactions to help present those choices to us. So just take those two bits, and there's lots more to think about. But more interactions, more frequent interactions, more, which means more data. Or you are young and just have to show up for a couple of well visits and screenings. Regardless of who you are, there are ways in which a health system or a health plan could engage with me in between those milestones. It would keep me engaged. It would keep that brine top of mind. And I think one of the ways in which we can imagine that happen is to start thinking about the product catalog in a more intentional way. What are some of the things that we could transact on? Every organization in healthcare has certain things that are transactable. What are they? Put them online, offer personalized choices around them, and then start thinking about what are things that we could do to nudge people along those journeys, reminders, making sure that they're engaged, taking their meds, checking in with their care managers, et cetera, et cetera. So there are a lot of creative ways in which we can replicate that. Until we reach that point, it just means that we have to be very thoughtful about how to apply the toolbox that consists of data, of machine learning algorithms, to really serve those customers with recommendations. It's not as easy as it is in industries that have more data about us. So it's really a choice in which architecture you build your solution around. So at Lirio, we have put a lot of thought into working with what we call objective driven AI architecture. It's really focused on what are we trying to get the consumer to do, work backwards from that, and really try to engage them and nudge them towards those milestones. And I think when you do that, you just realize how hard of a problem behavior change is, because frankly, all we're doing in an artificial intelligence world is to try and model the real world through data into the artificial world, right? Into the computer world. And let me tell you this, some secret that everybody knows about healthcare. Changing human behavior is hard, even human to human, right?
Right.
So imagine trying to do this in more of a digital setting. You really have to start taking advantage of some of the things that are harder for a human to human. It doesn't scale if I put a care manager, in the car next to me everywhere I go, right? It doesn't help that every time I create a red flag in terms of my behavior, I get a phone call from the call center trying to nudge me and influence my choices. That doesn't scale. So the human to human world, from a behavior change point of view, is hard. How do we really change, the odds in the digital world and really apply some of the things that the digital world offers that is, really, really helpful and useful? Meaning using data, automation, personalization to really keep those health journeys going and keep influencing and offering me choices every step of the way.
Yeah, that's great. Secretary Shulkin, you've seen technology in many different stages of the healthcare evolution, and there's been a lot of promises over the years about how this is going to work. And the topic of AI is not new, but it's come with a vengeance of late in terms of both the hopes and aspirations. Can you share some perspective on where do you see AI fitting having seen different iterations of this, and of course, many of us just came back from health where it was at least all the rage from a marketing perspective. Would love your perspective on AI and this notion of how do we really use it to get people to do better things and change what they're doing for the better.
First, I would just like to acknowledge that, understanding where healthcare is going, understanding what technologies are going to have an impact like AI, that's relatively easy to do. The hard part in healthcare is getting timing right. People who see where the future is can be off by decades because of the complexity of our healthcare system that is essentially designed to remain in the status quo.
Mm.
So, understanding how and how quickly AI is truly going to impact um, healthcare and healthcare delivery, I think is challenging to do. But it clearly is going to do that. I think my perspective on technology, on changes in healthcare, have changed over my career. When I first started out, I started in medical school to be a physician, where I thought the whole game, the whole purpose of what you do is to figure out what's the right thing to do for a patient. And of course, the Hippocratic Oath, do no harm. After finishing medical school, I did a fellowship in health services research where I thought the whole purpose was to determine what does the evidence actually tell you, because so much of clinical medicine is not based in real scientific evidence. It's based in intuition and sort of interpretive skills. But I thought, now if you can really understand the research and know where evidence base should point you, that's going to be the holy grail. And then I learned that wasn't enough, so I went to essentially business school, where I learned that knowing what to do clinically, knowing what the evidence was, you needed to integrate it with financial alignments to get people to change behavior. Then, as I began to do this, I began to understand that the biggest influence was probably non medical factors like socioeconomic determinants of care. So people's outcomes can be predicted better by their zip code than by their physiologic uh, description. And so you began to start understanding how you had to start thinking about care within the context of the social environment that the patient lived in. I think Marten's concept of behavioral nudging is exactly where this all leads us. This is the integration of clinical care, of financial aspects, of evidence based care, of socioeconomic determinants, but now distilled down to the personalized level. And when you start thinking about training this personalized nudging on large language models, this is where the AI comes into it. So you can actually start seeing what the data says about that person and what's going to motivate them and how to communicate with them and how to help them make the right decisions using this type of nudging. I think that brings all of this together and is ultimately going to have the biggest impact. And in fact, I'll sort of, maybe at the risk of overstating it, I've come to believe there should not be any major change initiative undertaken, whether you're on the provider side or payer side, without including an element of this personalized behavioral nudging. That without it, it's like running a car without gasoline, or maybe now a Tesla without charging it in an electrical station. You really need to include that type of behavioral economics, that type of behavioral, personalized messaging in with every major change initiative that you hope to succeed now.
Yeah, very powerful. Paul, what do you think your payer friends are thinking these days? It's a very challenging payer market. Utilization is up. Um, Reimbursement models and quality programs are changing. the cost trend, as I described in the beginning, just keeps going up. At the end of the day, 60% of people under 65, their employers paying that bill, and employers are frustrated. How does this notion of personalization become a reality in the payer world? And in many ways, maybe it has, but I'm curious what what you would tell your best friends today, uh, from your perspective, that are in the industry, about this concept that Secretary Shulkin just described, that personalization has to be there in this world that is so challenging from the payer perspective. What should they be thinking and doing?
Thanks for the question, Dan. I'm going to go back to what I said at the beginning, which is we have to see ourselves as the people that we serve see themselves or see us. We have to see ourselves in the same way that the people that we serve see us. I really appreciate that Secretary Shulkin brought in the idea of social determinants of health. And as you think about what Marten was talking about with this precision nudging, those are the things, those social determinants of health are the product offerings that we can layer in as we start to recognize who these people are. So the first thing that I would recommend to my payer friends is we have to know our customers. Who are they? Segmentation is so important here. I'm going to go back just a dozen and a half years because Marten talked about precision nudging. I want to talk a little bit about blunt force nudging, which is which is where we started, right? But when it came to stars, as an example, right? We were acing the test on HEDIS, but we were failing in CAPS. And so what we started to do, many years ago, is just start to ask our advocates when a member would call in to the call center or the contact center, we would ask the advocates to say, have I given you all the help and information you need? Because we want to be the best overall health plan for your needs. Those were two CAPS questions that were extremely important as it related to the overall experience. So at the end of the call, I would ask you, Dan, have I given you all the help and information you need? Because we want to be the best health plan for your needs. Well, you know what? When you ask that question, you have to deliver on the promise that you want to give them all the help and information they need, and you really want to be that best health plan for your needs. So what we started to discover in putting in that, what I would call subliminal advertising. If you remember old drive-in movies, you'd go to the drive-in and you'd be watching, a scary part of the movie, and all of a sudden you'd see this flash, popcorn. Well, that was kind of what we were doing, right? We were just simply trying to subliminally add, oh yeah, they do want to give me all the help and information they need when they were taking that CAP survey. Well, we have to deliver on that promise. And that promise is they needed help scheduling appointments for their HEDIS, for their gaps in care. They needed to understand that it was time for them to get their mammograms. And so those were the things that we really wanted them to do. But what do they want us to do? And that's where those social determinants of health become so important. And as we evolve and we get more sophisticated, and as Marten said, we start with the precision nudging. That's where we can start to say, okay, do you have food? Do you have pest control? Can we help you in this way? And whether it's through, and it really also matters what channel do our consumers want to engage with us. Some of them want to call, especially a more elderly population. They want to call because they want to have that relationship with the person on the other end of the phone. Other people, they want to text, or they just want a push notification. So what are the ways that we can actually engage with them through nudges? And the data part is really important, as long as everybody is singing from the same hymnal or the same data set. Because if they're not singing, if they're not using the same data set, then we're constantly nudging them with the same nudges, and they're just getting frustrated, and they're just getting, they're not having a good experience. So social determinants of health,
Mhm.
using that precision nudging just to get them, moving down the field, that ultimately they're doing the thing that we want them to do, but it takes us helping them to get the jobs done that they're trying to get done. That's extremely important. So that's what I would tell
Mhm.
my
Martin,
payer friends.
yeah, it's very very instructive. Martin, Secretary Shulkin talked about large language models. I want to talk about large behavioral models and how you're using them. And can you talk even specifically about those behavioral models and what it means for something like hypertension or diabetes or um, equity?
Yeah, so think about large language models as um, being very good at predicting tokens. So predicting the next word in a sequence of words, as an example, right? And we know that the more words it needs to predict, the more room there is for error. We talk about hallucinations, and so we try to correct that in different ways. In a large behavior model context, we're not trying to predict the next word in a sequence of words. What we're really trying to predict is the next behavior in a sequence of behaviors, or an action in a sequence of actions. So we're trying to understand really the ins and outs of how to target someone and leverage the information we have collected over time to really predict the way in which we most effectively can nudge them to try and get them to the target behavior. So, the way that this, of course, becomes useful is in journeys that are complex. If we had a simple journey and we just needed to get you to sign up for your patient portal, that's a relatively simple target behavior. If we needed to make sure that you did all the things right after having been diagnosed with hypertension, from reporting measuring your blood pressure on a regular basis, to making sure you check in with your physician on a regular basis, to make sure you take your meds, refill your prescriptions, etc., we now have to predict a lot more actions along your journey as a patient, and we need to make sure we're right every single time. So having a large behavior model behind the scenes is absolutely necessary in order to make the right predictions, to prevent a lot of these errors or hallucinations, to creep in and no longer help us really be accurate in how we communicate and offer help and choices to a patient along their journey. So chronic condition management is just a phenomenal sort of space where we know that the care pathways for patient are extremely complex. And oftentimes, people that have one chronic condition have multiple chronic conditions. And so, the way in which you can help patients by offering them choice, by reminding them, by nudging them along their care pathways, is infinitely more helpful in ensuring that they get to better outcomes than in very simple types of behavioral cases. But for us, we think that large behavior models combined with really using all of the information that we have about a person to really appropriately target them and personalize the outreach, we think that is going to be a game changer in really letting the digital world better help and empower patients in their daily lives.
Yeah, that's great. I know we just have a few minutes left. I'd like to end with sort of where we started this man versus machine, woman with machine. And what are your thoughts as we, you know, step into our near future with all the promise and hope that we have with this technology and the machine? Share your thoughts on woman with machine versus machine. What should we think about this being collaborative versus sort of combative? In terms of, is this binary? Do we need both of them? I just love your closing thoughts on that issue, and I'll start with Secretary Shulkin.
The first, what I would consider the first nudge is really a script, and that script being delivered with authenticity, and being delivered in a way that builds trust, where I'm looking somebody directly in the eye, or I'm talking to them, and I demonstrate empathy in my voice. Those are the first nudges that I can think of. Technology is only as good as who is actually leveraging that technology to deliver the nudge. So I think that we will get a lot farther with technology doing simple nudges without human intervention. And at the end of the day, humans will be there to support their fellow human beings, so that that members are getting the care that they really need. So it's a very symbiotic relationship, in my opinion. It is woman and technology, not man versus technology. It's going to be incredibly important for that technology to serve up the types of nudges that we want, but then there's also the human factor to say, maybe now isn't the time, or maybe we could actually nudge a little bit further. And those are going to be, very important
Hmm.
relationships that we will continue to have, and will continue to get better as a result.
Yeah, very well said. Paul, over to you.
Well, I think the headline is we live in an AI world already. Uh, AI is all around us, and whether it's on your remote control, your phone, uh, social media app that you're using or your kids are using, AI is everywhere. And so the real question is, we need to understand whether or not the AI that is being used and is under development for the future, if it is being designed to help humans live their best lives, right? So it's a choice around how do we use it for what purposes, and what are some of the principles that we use as we try to model the real world into this computer world. And I think some of the things that we really need to work on as an industry is just learning more about the potential. We have people that are extremely focused on, getting my kids to watch more TikTok and spend more time online. Why are we not sitting down with physicians and nurses to figure out how we can help them help patients live healthier lives, make better choices? So I just think it comes down to the very simple thing is people that often talk about this, as a choice, they may be missing the real point here, which is AI is here to stay. It's already influencing us. In fact, we could all agree probably that some of the solutions and apps that are being powered by AI are actually causing health problems today, right? So it's really up to the industry to make sure that we design and use it for good. I would say one last thing, because you started really setting the stage with, in framing this as a financial issue or a health economics issue. We have no choice but to innovate and really use technology to transform what is now an insolvent healthcare system, right? It's really important that we realize that even if you take some of uh, the sort of areas of concern about, how do you scale effectively an industry that really was designed to be human to human, if you take that out of it, you can say, well, we can't scale that anymore. The cost is just not um, uh, scalable, and so we have to figure out, both in terms of how do we teach and help clinicians to really harness the power of AI, design it for uh, their mission of serving patients, and also how do we make sure that we turn the tables on this very unhealthy financial state of the sector and get to a place where we actually can afford healthcare for many generations to come.
Yeah. Well, very well said. Well, I enjoyed this, learned a lot. Thank you, everyone. I thought it
Thanks
was
for
great.
having us, and nice to meet everyone.